A very good afternoon, respected chairpersons, faculties, and friends. Today I'll be talking about sacroiliac joint examination and the interventions that follows. Well, I bring greetings from GMCH Chandigarh, where I work. Now, if we talk that, why are we talking about like SI joint, first of all? We had such a nice, a presentation just before me, which talks about the lower back pain and the algorithm approach to it. Now, SI joint pain, basically the joint itself is very, accounts for around 15 to 30% of the all low back pains. And this pain can be, mixed up, or can the diagnosis may not be that clear cut, because so many pathologies have pain in that specific area only. But then how to go about it? The pain can be followed as a cause of an intra-articular cause or an extra-articular cause of SI joint pain. Intra-articular most being osteoarthritis, rheumatoid arthritis, but then the extra-articular causes can be, following trauma or fractures or myofascial pains. So we need to see that what is the cause of the pain. Now, pain typically, if you have a look at the presentation, so the pain is somewhere which starts at the level of the L5 and then it radiates. It is present in that particular area and hardly leaves the knee. Okay, so that's one of the differentiating features. The anatomy that I would like to talk about is that this is the, it shows that you have the sacrum and you have the ilium. And this joint which follows, we approach this joint from the posterior side. So this is the posterior aspect of the sacroiliac joint. It has an anterior and a posterior. So what is this? What we are looking at? So this is actually what we are looking at when you are looking at the sacroiliac joint when we are doing an intervention. So the space is very low and the intervention has to be done at a particular point. But intervention only follows once you have made the diagnosis. So let's go first to the little part of the anatomy. Sacroiliac joint itself is supported by a good amount of muscles and ligaments. The anterior part being a true synovial joint and the posterior part is more of a syndesmosis. What are the most important ligaments when we talk about the sacroiliac joint? If we look at here, the first is a sacrospinous ligament, which is from the sacrum to the ischial spine, right? The second being the sacrotuberous, which starts from the sacrum and goes on to the ischial tuberosity. Then one important one is the iliolumbar, which starts from the transverse process of the L5 and goes on to the anterior superior iliac spine. And one more which has now caught up the attention of everyone is the long posterior sacroiliac ligament, which starts from the anatomically, which is connected to the erector spinae muscle, the thoracolumbar fascia, and the sacrotuberous ligament. Now, the innervation. Innervation, which we target in the procedures, is the dorsal sacroiliac joint innervation, which starts from S1 to S3, with or without contributions from the L5 and sometimes with the S4. The ventral, we are not targeting the interventions. Why we are talking about the kinematics? So then there are two types of movements in sacroiliac joint. One is your antero-inferiorly, which occurs during weight bearing, and the other is posterior-superiorly, which occurs during non-weight bearing. So when we mix up this pain with the other type of pain like the piriformis or the other, so in that cases, when the pain is occurring with the movement of the joint, then we are looking up at the sacroiliac joint. But when it is purely a muscle-related pain, then we are looking at the muscle type of pain. So just a few points about the sacroiliac joint. It starts below L5. The tenderness can be felt at the SI joint, which is the Fontane's point, and then radiates onto the lateral aspect. Pain would occur on the abduction, aggravated by the provocative test, and increases. So we will rule out all these differentials. So this is the point where I was talking about the Fontane's finger. The patient would point out these points, and it will be just little low or medial to the level of your point of the posterior iliac spine. These are the provocative tests, which I'll take one by one. If any test which is more than 3 indicates towards the SI joint. Now, this is very important about the provocative test. If the provocative tests are negative, they hold a higher level of evidence rather than getting them as a positive. So more than 3 or equal to 3 gives a higher chances that the patient may be having a sacroiliac joint pain. So if we see the thigh thrust, in which we say the pushing is down and the other part is being, fixed. So we can have a look at it, and then we're pushing down, and then we are holding on, stabilizing so one hand is on the above, and we are trying to push it down, and the other we are stabilizing the other SI joint. The other is the distraction, in which we will try to distract the SI joint on both sides simultaneously, right? The other would be the compression test, in which the patient would be in the lateral side, and we will be pushing on the joint and try to see whether the compression test is positive or not. If the patient complains of pain, it is positive. Then the Faber or the Patrick test, in which a figure of 4 will be formed, and the patient would be at the knee level, it will be pressed, and the other will be distracted. So if the patient complains of anterior pain, it becomes more likely like a hip pain. If it's a posteriorly, it is a SI joint pain. The other tests are the Ganselin's test. So in this, the right side of the SI joint is being focused. So if we see here, the knee of this is being bent and being pushed, and this the right side is being hanging over the table, and we are trying to check for the right SI joint in this case. So we are trying to check on this. The other is the resisted hip abduction, in which we ask the patient to lift the leg, and we are trying to resist the abduction. So there's n number of tests. So we can, but as I told you, the list of 6 tests, and the first 3, 4 are the one which are more sensitive, right? So how do we look at the evidence? So look at the evidence is, as I told you, that if you have negative tests are more, specific for ruling out SI joint than having it. And if you have them, at least you should have more than or equal to 3. The history and physical examination help us, and more is a gold standard is your intra-articular injection. So red flag signs has been already been told by the previous speaker. Now in SI joint, if we look at the investigations sometimes may not give us all the evidence, but yes, the SI joint X-ray, we can grade them according to the joint, like are there any suspicious changes are there, or there is any minimal abnormalities there, or there's a univocal. So this is the, we can look at the X-ray and also rule out the other causes, which may be the cause of pain in that area. CT scan and MRI can guide us, but they are not mandatory required for the diagnosis. So diagnosis is basically based on the history, examination, provocative test, and your gold standard is your intra-articular SI joint if you're looking for an intra-articular pathology. So your CT scan will guide you about the erosions and the soft tissue by the MRI. So how we look at the SI joint? It can be an extra-articular pathology, it can be an intra-articular pathology. So what is very important to notice, then when you have an extra-articular pathology, and once you have given a combination of the diagnostic block, and after that, if the pain relief is good, then you can very well repeat it. If it is less than that, then you have to target the lateral branch blocks in the SI joint. And more important on the intra-articular pathology is when you have given an intra-articular block and the patient has a good pain relief, then you can repeat it. But if it is not there, then you can consider use of PRP, although the evidence is still not very great about it. But the most important point is that we need a surgical consult, which is a very important point when we look at the intra-articular pathology of an SI joint. So these are the fluoroscopy landmarks that we have to see if you're planning a procedure. But what is very important to know is that when you're targeting the sacroiliac joint space, so what is your target of area is your lower 1/3. Don't go very below it because then you are going to hit your sciatic. So this is the lower 1/3 is the area of your placement of the needle for the diagnostic SI joints. So if you look at the fluoroscopy, AP view will tell you the indication of the inferior recess. The oblique contralateral oblique is the view that is required when you're putting a needle in the SI joint, and lateral will give you the depth position. So this is what I was talking about, that your needle tip position has to be below your posterior superior iliac spine and in the lower 1/3 of your joint. So this is the needle direction that you would be seeing, and similarly you will adjust your C-arm accordingly. So first would be your patient in a prone position, all monitors attached, and then first you will take is your posterior view, PA view, and you look for the position on the spine where your sacroiliac joint will be visible to you, and then you will do a contralateral oblique. right? Contralateral oblique would be required. And the needle positioning will be under the tunnel vision. So here if you see that initially we had done a AP view and then we had a contralateral oblique which will be very much visible here. So if you're targeting this, so this is a contralateral oblique that you're targeting. This is the OT preparation that you have to do. Have a needle, a 22 gauge needle you can use, and then the contrast would be required would be very low, something like 0.25 mil, because the whole space is like of the SI joint, the capacity is something like 1.5 to 2 mils. So not much you will not be able to inject. Have a contrast and also so this is one of my patients who had underwent a surgery, and following that she was having an SI joint pain in which we were doing it. Some dye has gone out, so we waited for the optimal position. And then for the depth, you have to target the anterior 1/3 of for the correct placement. So the contrast, should not be, ideally the contrast should be visible. When you move the scan also in the contralateral oblique, your scan should be visible in the joint space only. If your needle tip is not correctly placed, then it will move away from the joint space. That is a very important point. And once you have placed the needle correctly in the end-on view, the gun barrel view, the needle tip placement, then you give the contrast, and the contrast will be spread inside, and some might come out if you give too much contrast. And like this is the not a good way of doing it, because this is not in the space and it is an incorrect position. And this is the ultrasound, approach to target the SI joint, which is quite popular nowadays. And this is one of my patients in which I had done a USG guided, SI joint placement. So the needle tip position would be placed here, you can see it. This is also possible at 2 levels. How you can do is that you can do it at the level of the inferior SIJ, where the probe placement is here in the lower 1/3, and here you will see the muscle, which is a erector spinae muscle, and here is the recess. The recess is out here. So I had done this approach in my patient. The other approach is when you do it little higher up, but always stay below the posterior superior iliac spine, which is at the level of the second foramen, the sacral foramen, and then here the recess is little narrow, so you can choose whichever is your preference. But yes, intra-articular are valid to see the diagnostic block, and your lateral branch block, they are good for your interosseous ligaments or dorsal SIG for the extra-articular SIJ joint pains. Good. Use any of the methods of, don't do a needle blindly. Do it, use either fluoroscopy, ultrasound, or you can use a hybrid technique as well. So these are the few pictures I wanted to show you regarding the strip lesioning, where you will be, aligning so in that we had put it on the contralateral oblique and little cranially if you are not getting a good view. But for your sacral lateral branches, so what you have to do is you have to align the anterior and the posterior sacral foramen. So that is why the C-arm position is like this. And then you will plan for your strip lesioning of the lateral branches, which at the S1, if you are targeting for the right side, it will be at the 1 o'clock and 3 o'clock position or 5 o'clock position on the right side. So you can use this strip lesioning, where you can use for 90 seconds at a temperature of 80. The other option is the cooled RF, which can be used. And now coming up is your cryo. Cryo is also coming up. So what is the evidence? The evidence is when you do a sacrolateral branch radiofrequency ablations, so it is seen that they are more effective more than 3 months and have resulted in more than 50% pain relief. So the level of evidence is coming up for these. And so the moderate level of evidence is there. For PRP, the evidence is still indeterminate or still insufficient. And now coming up is your cryoablation, which is showing very good results. But yes, we need to wait for the evidence, which is currently not available in the latest consensus guidelines, which has come in 2025. Complications, you can have infections, hematoma, but it is a very superficial type of a joint. Don't expect too much complications. But yes, if you do the damage to the surrounding structures, then we can have a weakness, or are targeting the neural structures. So that is very important. So what did we gather out of it? We gathered good amount of good history, examination, treatment is important, and follow-up is very, very important. So thank you so much.